with the case report I'm going to present today, we want to show you clinically preliminary data about a new protocol, how to treat teeth with bone fenestration. So I want to introduce you Davide. Davide is a male, 16 years old. He is a second class following the angle classification, and he is undergoing a retreatment, an orthodontic retreatment, because with the preliminary treatment he didn't obtain the correct outcomes. So he presents an impacted cuspid in the upper maxilla, in the left upper maxilla, and the parents' request was to minimize the treatment time because the patient had been under treatment for several years. So the orthodontist, after careful consideration, sent us the patient for the extraction of the cuspid because considered impossible to treat this cuspid with orthodontical treatment, traditional orthodontical treatment. So in accordance with the orthodontist, we decided to try an autotransplantation to maintain the tooth. And now I'm showing the procedure. The cuspid has been extracted with a traumatic technique. We try to preserve the buccal wall well attached to the root surface, but we did not succeed. But this is the picture of the cuspid just after the extraction. How you can see the apex was open, the patient was 16 years old, and we were able to preserve 3 out of 4 parts of the follicle, and we were able to preserve the periodontal ligament, not on the vestibular part, but all over the other part of the root. So the idea was to create a surgical site within the bone crest to insert our cuspid and to fix the cuspid into the bone. But the main problem here was that the cuspid could not be fitted in this space because the premolar root has a shape that was bended over the midline, bended in mesial part. So we decided during the surgical procedure, we decided with the sterile procedure to cut the lower third of the premolar root to create the space to fit it in our cuspid, and then we fitted the cuspid in that space. So what is the rationale behind this kind of procedure? We can describe 2 different rationale, the endodontic and the periodontal one. So starting from endodontic one, first of all, the extraoral storage time was so important. In literature we found that this influenced so much the pulp vitality prognosis, and we took less than 15 minutes, but now we have to improve our technique, we have to analyze more details, we have to be we have to pay very attention to this kind of procedure. Then we know that the teeth with incomplete apex have a good prognosis, more than 90% of the pulp healing during an autotransplantation compared to teeth with complete apex, with a closed apex that not go over than 15%. Then the root resection positively affect the survival of pulp cells. So we want to trust in the vitality of the premolar. And then we know that root resection of transplanted tooth improve the healing during the following month, during the following period after the autotransplantation. The periodontal rationale can be summed up in 4 points. First of all, the importance of the extraction that must be atraumatic. You see that we try to preserve also the buccal wall because the preservation of the periodontal ligament permits to obtain a good vitality, a good healing for our tooth, and the preservation of the periodontal trigger the healing of all the periodontium. Then we had a bone regeneration on the buccal side. Yes, the absence of the periodontal ligaments permits not a periodontal regeneration, but maybe a bone regeneration. And this new bone regeneration guaranteed not only the absence of a pathological probing depth, but also prevented soft tissue recessions. So coming back to our case, we decide to treat the tooth as if it were an implant. The width of the ridge did not allow us to place the cuspid without a bone dehiscence. So we decide to reconstruct the bone dehiscence with a fully resorbable collagenated biomaterial in order not to have slow resorbable or not resorbable one, but to obtain a completely substitution of the graft in the time with new bone of the patient. And in these cases, in order to be super very biological, we decide not to use membranes, but LPRF membranes only. This is the suture and the splinting of the tooth in the bracket of the patient. This is the immediate post-op. We can see the graft well attached on the vestibular part of the tooth. And this is the storytelling about Davide, starting from September 2019, January 2020, April 2021, and 3 years of follow-up in October 2022. We can see the correct apicification of the canine and the preservation of the periodontal ligament on both teeth. This is the 3 years follow-up CBCT. How you can see there is new buccal bone on the vestibular part of our cuspid, and we can see that the graft have been resorbed and substituted with new bone of the patient. So we asked to our endodontist, a blind assessor, to check these teeth and to analyze the probing depth and to analyze the vitality. The dichotomous test was positive with no probing depth. We had a medium thickness biotap, 0.8 to 1 millimeters, similar to other teeth in the mouth of our patient. And then we asked him to remove the splint. Tooth is vital, yes, okay, please remove the splint and make a direct composite to restore the static shapes. But we decided to ask to another blind assessor because we wanted to have concrete numbers. We asked him to check with a different kind of test, not the dichotomous that gave us just yes or no, but with an electric test. Digitest is an electric test that gave us numbers, so we can have concrete relation of the vitality of our teeth, and I can see these are the results. The vitality is good. So as the endodontist shows, even if you don't see the canal, tooth is vital. So this is Davide nowadays. Someone of you can ask me, will it resorb? Yes, this is a chance. This is a possibility. But if it were to be resorbed, I will have both time for our guys, for our patient, and I will do an implant when he will be older, 30, 35, who know when. And gaining time, moreover, I already reconstructed our tissue during the primary surgery, and I will be able maybe to do a post-extractive implant. So I'm going to conclude. In according to our view, we can find this treatment option a good choice, a good alternative to the extraction in that cases where orthodontists consider impossible to disinclude with traditional treatment, or as an alternative to reduce treatment time. Nowadays, in which we are asked to be more effective and efficient, and with a correct plan supported by the literature, we know that this kind of treatment has a high percentage of success in this kind of elements. And yes, we know we need more research, more information, we need more cases, but we want to trust that this option can be an extra arrow in our quiver. So I want to thank you all. Thanks to all my team.